Good evening. Today we have the privilege of discussing with our special expert guest, Dr. Robert Hindman, clinical psychologist and faculty member of the Beck Institute for Cognitive Behavior Therapy from Philadelphia, USA. Dr. Hindman completed his BA at the Columbia University and his doctoral degree at the Catholic University of America. His research focusing on stress, anxiety, and mindfulness, which led to the development of 2 mindfulness-focused stress reduction programs for a student population. Besides co-authoring book chapters on anxiety, mindfulness, and cognitive behavior therapy, he has also written the Beck Institute online courses on CBT for anxiety disorders, CBT for suicide prevention, and integrating mindfulness into CBT. In his role as a Beck Institute faculty member, Dr. Hindman conducts individual and group supervision for therapists looking to improve their skills in cognitive behavior therapy. Dr. Hindman, thank you very much for accepting our invitation.
Of course, great being here.
Okay, so I would like to start our discussion with a brief description of cognitive behavior therapy. Specifically, what is the mission of Beck Institute for Cognitive Behavior Therapy and of this psychotherapeutic approach in general?
Well, for the Beck Institute, the reason it was developed by Dr. Aaron Beck and Dr. Judith Beck was they're professors and looking at how, the research for certain conditions, how to treat them, shows there's certain really effective strategies. But then when you look at what people actually practice in the field, they're not practicing what the research shows is most effective. Mm-hmm. So they developed the Beck Institute in order to help train therapists to do treatment that actually works, as opposed to a lot of therapists just do what feels right to them. Mm-hmm. So that's the whole idea of the Beck Institute, is let's get people conducting therapy in the way that research shows is most effective. The good thing about that too is it's constantly changing. So it's not just, when this was originally developed in the 60s and 70s, it just stays that way. Every year, new research gets conducted. CBT is constantly changing. And then just for a brief description of cognitive behavioral therapy, the main idea is something called the cognitive model, where it's not the situation itself that leads to our reaction, which can be how we feel about something and how we act, but it's how we think about it. Mm-hmm. And when I'm going over this with my clients, I'll use an example of, let's imagine you have a good friend or family member, you texted them, it's been about 5 hours, you haven't heard back, what would go through your mind? Mm-hmm. And then, some people might say, well, they're ignoring me. Okay, if you think they're ignoring you, how are you going to feel? Angry. What could be another interpretation here? Well, that, they're injured or hurt, and, what would be your emotion there? Well, I'd be nervous, I'd be anxious. Okay, so you can see how same situation, but the way you think about it is then going to influence how you feel and then probably what you do as well. That's the basic kind of idea of CBT, the cognitive model. To expand on that just a little, each disorder has its own cognitive model with that. So depending on the disorder, there's different factors that are going to contribute to the disorder being developed and then maintained as well. So like, for instance, for depression, you have different beliefs get activated, something called the negative cognitive triad beliefs, where negative beliefs about the self, about other people in the world, and about the future. And then when those get activated, people tend to pull back from life, and then they spend a lot of time ruminating. And then that's what drives the depression further.
Yes, very interesting. So we talk about specific cognitive contents for each particular disorder.
Exactly.
The treatment plan involves discussing into cognitive restructuring and applying different techniques to actually modify or change the contents of these beliefs. So, if I understood correctly.
Yep, exactly. And the way you can think about it is you're trying to change the beliefs, and then with that, thought content can change, but we're not actually changing thoughts as they show up. We're just changing our relationship to thoughts.
Very interesting. And we use different strategies for doing so as practitioners, and one recent direction in research and practice, and I know it's your expertise, is on mindfulness. So how can mindfulness be integrated effectively into CBT?
So that's where like I do a lot of supervision and I'll hear sessions of clients using mindfulness. What they typically do is just teach a mindfulness meditation and they say, so let's sit down, let's focus on our breath for 5, 10 minutes or however long. And then the idea there is that's supposed to then lead to a calming effect and it's supposed to help clients not get so caught up in thoughts. But that's not really integrating mindfulness well into CBT because we engage in thought processes because we hold beliefs about them. So we can take depression as the example again. The thought process in depression is rumination. Rumination is focusing on problems, thinking about why they're there, and sometimes it's trying to come up with solutions, but you never really get to a solution. So people ruminate because they hold positive and negative beliefs about rumination. Positive beliefs that it's helpful, like I need to ruminate in order to figure out why my life's so terrible or why I feel so bad. And then the main negative belief is that it's uncontrollable. So if people just go straight into mindfulness for depressive rumination, it's not going to likely be that effective because the client's going to still think they need to ruminate, and then they're going to believe they can't stop ruminating. So kind of the way I like to teach mindfulness, and mindfulness is just being focused on present moment experiences and an accepting and non-judgmental manner. I'm going to try to replicate the experience in session as the client's going to use mindfulness outside of session. So I'm going to have them, let's say we do a mindfulness of the breath exercise where you focus on breathing. And then when you find yourself getting caught up in thought, you just refocus it back. I'm going to do something called a rumination induction. So I'm going to have the client close their eyes and start ruminating about the same content they would be ruminating about outside of session. From there, I'm going to guide them through the mindfulness exercise. And then afterwards, I'm going to check in with them and I'm going to do cognitive restructuring. So I can ask them, generally, how was that experience for you? One is getting feedback if it was actually helpful, because some clients will say, that was terrible, like I couldn't do that, like my mind was all over the place. Okay, mindfulness might not be good for this client then. Other clients, I'm going to get at the uncontrollable belief there. So, you started ruminating about kind of how your life's going, how terrible you perceive it to be. Then we switched over to the mindfulness. Were you able to let go of that rumination? Were you able to kind of disengage from it and then focus on the breathing process? If so, I can then follow with, so what's that say about this belief of yours that rumination is uncontrollable, that you can't do anything about it? Moving forward with that too, there's two different kinds of mindfulness practice. There's something called formal practice and informal practice, and this is also where a lot of people get in trouble. Formal practice is actually sitting down to do the meditations. So I'm going to take 10 minutes a day. I'm going to cut out any distractions, sit down and focus on the breathing process. Versus informal mindfulness is, let's take those principles that you learned during the meditation and let's apply those to life. So a lot of people just do the formal. They say all you need to do is meditate for 10 minutes a day,
Mm-hmm.
and then that's going to help you throughout the day. Versus the way I think of it is the formal practice is really building a skill. Let's build the ability to notice thoughts, to notice when you're really caught up in them, and to help shift focus where you're not fully absorbed in them. And then the informal mindfulness is really where the important work is. So, okay, when you notice yourself ruminating, it's taking out of that experience and then just redirecting like you would do during mindfulness. Oh, there are those thoughts again. I've noticed the thoughts. I don't have to think more into them. I can just take a few breaths and then get back to what I'm doing. And that's really where a lot of the change happens, not just in doing the meditation itself.
That's very interesting, and thank you for this clarifying answer, because I think many people actually think differently about mindfulness and don't really understand the purposes of this technique. So yes, we talk here about changing the way people think about their thoughts actually, and the way they relate to these thoughts, so that we can then change them and work cognitively more. Okay.
Exactly. And what happens too is I'll typically do standard CBT cognitive restructuring. So looking at a thought, okay, what's the evidence for and against, using Socratic questioning before I get into mindfulness, because I want clients to understand that our thoughts aren't necessarily always accurate or helpful before they learn to just disengage from them. Because otherwise it can be a lot more difficult to just kind of disengage from them with mindfulness.
Yeah, okay. Okay, and when you said there are some clients for which mindfulness can be actually the solution, or it's not appropriate, or you kind of anticipated my next question, that would be if there are any client types or any situations in which mindfulness could be contraindicated, for example, in psychotherapy, because we think about it as a solution for many, many psychological difficulties, almost all. So.
Yeah. It's typically going to not be as helpful for someone who's under a lot of distress. So think about someone in a suicidal crisis. So if I have a client who's in a suicidal crisis and I say, I want you to, most meditations are eyes closed. So I want you to close your eyes and really focus on what's going on cognitively and emotionally. That's going to bring them into into contact with this distressing content. And it can really rev up the intensity of their distress, which then might lead to the hopelessness and unbearability piece that can drive more suicidal behavior.
Okay.
So in those cases, I'm doing more distraction kind of strategies. So you can think of like dialectical behavior therapy and their tip skills, where a lot of it is let's take attention away from thoughts and away from unbearable emotions, and let's put them towards some kind of more neutral stimulus. So yeah, with those clients, that can really just get them involved more in the process that revs up the sense of hopelessness. So I'm typically not going to do it with those clients.
Okay, okay. And what about psychotic clients, for example, or clients who have psychotic-like experiences? Is it appropriate for them to use mindfulness, or?
It can be tricky to some extent because, with psychosis, a lot of times there's not the awareness of the psychosis, and they think that everyone's just lying to them and it's this conspiracy why they have a diagnosis. Sometimes I'll work with clients with a psychotic disorder, and let's talk about auditory hallucinations.
Yes.
So, you need to get at beliefs about the auditory hallucinations. And a lot of clients will say, I know this is part of my diagnosis. These voices are just really unbearable. I can't stand them. So then they cope with putting on headphones and listening to music. I do mindfulness with those clients of the auditory hallucinations. So what I can do with them is, when they show up in session, I can have them close their eyes and I can have them just kind of notice what the sounds are like. So a lot of times it's voices that are saying words. Sometimes it's just like mumbled sound. But what I'm trying to do is help the client take note of the experience without having the reaction to it. Because what
Okay.
happens is clients will notice the hallucination
Mm-hmm.
and then they'll start thinking about it. This is terrible. When's this going to go away? I can't stand this. So what they're doing is they're adding an emotional experience to the
Exactly.
auditory hallucination. So if I can get clients just to take note of it, to cut out that negative reaction to it, to just observe it as sounds like any other sounds that are ambient in the environment, birds chirping outside, cars driving by, and then get them to not focus so much on them, to shift their focus to what's going on in front of them as opposed to what's going on internally. That can help with the process because stress is usually going to make them worse. So if I can take away some of the stress response to them, they're usually going to fade a lot on their own. And if I can get that hypervigilance to them and have them focus more on the present environment in front of them externally, then that's going to take the subjective intensity away and it can let them kind of fade more over time too.
Okay, that's very, very interesting, and it's fascinating how many applications we can have to actually differentiate between the description part actually from the evaluative part of the emotion, of the sensation, or any experience, even if we talk about psychotic experiences. Okay. So still, we know that some clients might use mindfulness in a wrong way. For example, with anxiety disorders, we know that mindfulness can be a reassurance strategy sometimes. So is this the case in patients with or clients with anxiety disorders?
Yeah, you have to be very careful with a lot of types of clients where they use mindfulness as avoidance.
Mm-hmm.
So a client will say, I'm feeling really anxious. I hate feeling this way. Let me try to use mindfulness of the breath to make this go away. Or think of an OCD client.
Yeah.
OCD a lot of times is fear of thoughts. So I'm having these intrusive thoughts. I hate having these thoughts, and I'm going to use mindfulness to get rid of them. So
Right.
that's where sometimes when I'm training, I'll say there can be a fine line between mindfulness and avoidance. We need to really emphasize to clients that the purpose of mindfulness is not to eliminate these experiences. Like I like to tell clients, we cannot control thoughts. We cannot control emotions. I usually say, if we could control emotions as human beings, then I'd be out of a job because you wouldn't need a psychologist to help with these experiences.
Yeah.
All we do is we're changing our relationship to them. And then I'll go through like a process of what happens with the client. So let's say an anxiety disorder client. Anxiety shows up, and what happens? You focus your attention on it and you tell yourself, I hate this. This is terrible. When's this going to go away? Anxiety's energy for a challenge.
Mm-hmm.
So when you perceive anxiety to be a challenge, it just keeps on getting more intense. The
Mm-hmm.
more you focus on it, the more subjectively intense it's going to get. I don't
Right.
want to get rid of anxiety. I just want it to be proportionate to the situation. If there's nothing inherently stressful or dangerous about the current situation, anxiety isn't needed at such a high intensity. So let's use mindfulness to get at these processes that are contributing to it. So what
Mm-hmm.
are we going to do? We're going to notice anxiety, tell yourself, I can't control this. I can't make this go away, but I can remind myself that, it's okay to experience this. I focus on tolerating as opposed to kind of avoiding or reducing. I can tolerate this and I can let this be there. And again, think of like mindfulness of emotion. The whole idea is to acknowledge the experience, to not judge it as being, good or bad, and then just to let it play out on its own. So when you accept emotion, what's that do cognitively? It allows you to focus back to the environment. Because if I
Right.
don't have to control my anxiety, if I don't need to try to make it any different, then I don't need to focus on it. So I'm going to focus on my present moment experience externally. And again, as long as there's nothing right in front of me going on that's challenging or threatening, that anxiety is no longer needed. So it just fades on its own. But I tell clients that can be the side effect of mindfulness. That's not the
Mm-hmm.
purpose.
Mm-hmm.
The purpose is just to have a healthier, more productive relationship to your emotional experiences.
Mm-hmm.
And this kind of, as one more side note here, like in talking about anxiety and clients saying, I want to get rid of my anxiety, it's just too much. I say, my typical goal in therapy is not to get rid of emotion, it's to help you be willing to experience all emotion.
Mm-hmm. That's very nicely said, and I think it relieves a lot of pressure for clients to be able to experience some emotions and accept them so that they are more willing to maybe accept other perspectives from the cognitive point of view so that they can change thoughts afterwards. Yeah.
Definitely, yeah, because like the type of emotion, so the valence of the emotion, the content of the emotion, and the intensity are going to really influence how we think about things. So if you can, some people call it the top down versus bottom up processes. Top down, you
Right.
focus more on the cognitive, bottom up, you focus more on the emotional.
Yes.
So you can consider mindfulness more of a bottom up. Let's
Mm-hmm.
just focus on the emotion. And then when that can resolve to some extent or change to some extent, then the cognitive stuff just shifts with it.
Okay. Very nice. Very interesting. So I would like to switch now to the topic of your expertise in supervising therapists and in cognitive behavior therapy. So what do you think are the main skills that CBT psychotherapists should have?
I mean, if you go based on the research here as well, like the
Mm-hmm.
number or the most important factor in client outcome is the therapeutic relationship. So when I hear supervisees doing CBT, a lot of times they just go overboard and being very cognitively focused, and they don't actually do the standard counseling skills, empathy, validation, just connecting with the client. So a lot of times I just have to start from the beginning of, hey, let's be a human being with this person. Let's stop just asking them what they're thinking every other second.
Mm-hmm.
Once you get that down, one of the things that really differentiates CBT that a lot of people don't do, even who define themselves as CBT therapists, is having structure.
Okay.
And and within the structure, you want to accomplish a few things in each session. Like you need to do a mood check to be able to rate their progress. You need to set an agenda. You need to review the action plan. One of the main problems I see that's really important in supervision is how therapists define the purpose of a therapy session to their client, where they think of it as you come in, you see me for an hour a week, let's say, and then that's where the change happens. Versus the way I talk to my clients about therapy is most therapy happens between sessions. So what we're doing is we're figuring out what's going into this presenting problem or diagnosis. We're figuring out what ways can we intervene that are going to correct this where it's going to help you reach your goals. And we'll come up with a plan or teach you some strategies. But most therapy is what happens between sessions. So that's a
Okay.
huge thing I do in supervision is people don't emphasize the between session work, which originally was called homework. Now they call it
Right.
the action plan. That's
Mm-hmm.
just kind of thought of as an afterthought. So
Mm-hmm.
that's one of the main things. So it's basic counseling skills, it's having structure and knowing the purpose of the therapy session versus the work outside of session.
Okay, thank you. Thank you. I think this is very important for us to take into account. So I know you were the supervisor of Dr. Popa, who is at the moment the only CBT certified clinician at the Beck Institute in our country. So what do you think about the development of CBT in Romania in general? That would be my other question. What is your opinion?
Well, I mean, He's an absolutely incredible psychologist. So go see him if you need help. But part of it is like I think of my role at the Beck Institute where I started off as a postdoctoral fellow. And I received a ton of supervision there. But the most important thing was getting supervised about supervision. So you can have incredible skills, but it's really important to be able to train other therapists in those same skills. So, given him being a Beck certified clinician,
Mm-hmm.
what I would say is most important now is kind of spreading that to other people in Romania,
Right.
being able to train other therapists to have those same skills, because then there's going to be so many more people who are able to be helped.
Right, thank you. So we are happy to be around him, so in the department, and that's very good. Okay, and maybe a last question would be, what is the future of CBT in general? What do you think about the future directions, delivery mode, or techniques, or any other developments?
The kind of from my view on this, I think CBT traditionally, at least earlier on, was very thought content based. So let's notice automatic thought content. Let's see how it might be exaggerated, and let's evaluate this so you can come to a different conclusion versus, you know, now it seems to be heading more towards process based. So let's figure
Mm-hmm.
out all of these processes
Right.
underlying the content.
Mm-hmm.
And there's a book out by it's Dr. Stefan Hoffman and Stephen Hayes, he
Mm-hmm.
does the acceptance and commitment therapy, but
Mm-hmm.
it's called process based CBT, I believe.
Mm-hmm.
And the idea is you can go by diagnosis, but underlying kind of a lot of diagnoses, like think of comorbidities, there's these standard processes that are happening, whether it's thought processes, whether it's like, attentional processes or behavioral processes. So let's focus on a lot of the process piece to it as opposed to just the content, if
Okay.
that makes any sense.
Yes, yes. So it's about actually identifying the mechanisms involved in symptoms, actually in the maintenance, their onset, and so on. And then start.
Exactly. Yeah.
Mm-hmm, mm-hmm.
Mechanism based.
Right, right. And in CBT, we talk about negative automatic thoughts, I guess, and all this cognitive content, especially, that could maintain
Yeah,
symptomatic.
and yeah, when I'm working with clients, all I'm thinking about what are the mechanisms that are keeping this going? And then
Mm-hmm.
in terms of interventions, you can use a number of different interventions to get to the same mechanism. So
Okay.
like mindfulness is one of them, standard cognitive restructuring is another, you can use metaphors. But I'm just thinking purely as opposed to like what are these mechanisms in place? And that's where it seems like the kind of research in the field is heading.
Okay, okay. So thank you very much for all this valuable information and this captivating discussion.
Of course, yeah. Hopefully it wasn't too confusing.
For sure, for sure. Thank you very much, and thank you very much for watching us. Have a nice evening.